Although they say a donor may live and may not have any complications, a living donor has a risk of about 5% of complications. So, one has to be aware, understand and then give consent rather than believe, oh, there is no problem. Family support also needs to be assessed. So, a donor, if he comes alone and he just identifies only one person as a family member, then we will have to work more intensively and see what is the relationship, is there any support if something happens to the donor. So, a family support also needs to be assessed properly, thoroughly, because there may be many complicated aspects in the family dynamics, family relationships and single family, then multiple families, nuclear family. So, that itself is a very complex area. So, how you assess the support, or is it also vulnerable for manipulations? Then one has to assess in the donor about psychiatric disorders, there where we have the expertise and we feel comfortable assessing the family and other issues, maybe the psychiatric social work people assess it well. Whereas, when it comes to psychiatric disorder, the person who is donating is a fit in that particular moment, and subsequently also, but once the organ is retrieved, subsequently also the welfare has to be taken care by the supporting family. Unlike in placebo drug trials where a person is continuing to take, then the earlier question like when do you assess competence in the beginning or later or continuously. So, here it is more important before you retrieve an organ in a living donor, and subsequently also how you continue to take care or maintain the support, clinical, family, that social, legal and these kind of aspects. That means, it goes beyond the four walls of the clinics. So, in psychiatric disorders we have to rule out mental retardation and schizophrenia, then mood disorders, substance abuse, personality disorders, cognitive deficits, dementia, then varieties of conditions. So, we have to quickly assess whether the donor has any of these problems. I will come to later certain case vignettes where we have come across people with these not fulfilling some of these requirements as far as the donor is concerned. Cognitive deficits I have already talked about. Psychological distress. So, any psychological distress in these people we have to evaluate, although the donor tries to cover it up and they try to, because there is lot of time goes in between. A recipient cannot directly ask a relative, please give, and there is some kind of an indirect coercion or manipulativeness will be there at some point of time. The recipient who is determined to take an organ, because in even recipient there are many variables are there. There may be a recipient who is not interested or who is depressed. The moment you treat depression, he wants to, and if he wants to, whom and how he chooses, how he breaks the news, how he indirectly manipulates or creates an altruism, and these are quite complicated area. So, psychological distress initially will be there in both recipient and donor, and even in the treating team, including us. When I evaluate these people, when they refer to me in a day 2-3 cases, it is very stressful for me, because I can't elicit altruism, I can't elicit psychological distress, I can't rule out psychiatric disorders in 15 minutes in my OPD. I need hours, and also I have to assess these things in a very different way in every patient, because if there is a standard format, if you have a questionnaire, multiple choice question like that, and if I do that, there are people who may exactly by heart what answers to give so that it gets clearance. So, I have to change it in such a way that I first assess family aspects, then I go back to the occupational related, then I go back to mental status, then I go back to what they have been told by the transplant team and what is the future plan, what about the job. And so, it is like a detailed workup of a patient, and if I ask in a standard fashion, people by heart this, like how medical students can exactly know the MCQs and next exam they can hit. So, they can answer these questions. So, we have to ask these questions in such a way that I also should not have a pattern, they also should not come to know there is a pattern. So, this is to prevent illegal kind of thing. So, when there is very legal, there is no problem, but then that never happens. So, we cannot take it for granted. So, psychological distress is a very difficult situation. Even to begin an interview in these people is extremely difficult for me, because they will come with the family members, the recipient sitting is outside, we do not know who has come, are they really related or they are appearing as though they are related. What questions to ask? Why are you donating the kidney? Or have you thought alternatives? Or are you trying, is there any kind of an indirect or a direct benefit you are likely to get? and how long you know this recipient, how close you are as a family members, how often you meet. Only during this time they start meeting close. For 10 years somebody would not have seen each other, and around this time people will say, oh, every day they are my neighbors, and then we meet each other, oh, extremely nice person, I want to give, that is one of my major wish in life. But later on you come to know that these are all kind of a prepared, kind of like an interview. People come, so psychological distress may not appear, and how to elicit that, etc. There are many points like this, so time does not permit me to go into each detail with examples. So the components, it is a physician's duty. It is not the duty of a primary physician who is seeing the patient and who thinks by doing a particular procedure or intervention it is going to make a change in quality of life and time to death. Then it is the responsibility of the physician to orchestrate all these aspects. So they cannot say, I have seen, I can give you, this is the solution, so all others have to help me to solve this. So then they are there, but then it is primarily the physician's duty. Patient's rights is another component. One has to be aware what are the patient's rights, and cost effectiveness, particularly in developing countries. So we have to be sensitive for cost effectiveness, whether the patient can afford subsequent to transplantation, what are the resources, and then whether he gets free medicines or subsidized medicine, or somebody is going to support, and whether he is going to have a work. Particularly this becomes easy if patient post transplantations continues to work. If he does not work, then there are various other aspects related to cost which will complicate the matter. Scientific progress, this is another component one has to keep it in mind while participating in these clinical issues. So like I mentioned, psychiatric social work, our method. So I am going to discuss about what we are trying to follow, although it is not a perfect method. We are trying to understand the process, trying to evolve that, and we have a psychiatric social worker who works with the nephrology team, and she is most of the time is able to elicit already whether they are related or unrelated. If related, then various other issues related to that, and whether they are giving consent. If unrelated, then they come to the ethical body. They are unrelated donor. I will come to later what is related, what is not related, and how our Transplant Act defines that, and what are the loopholes there. There is one psychiatric social worker in nephro team. There is another psychiatric social worker in cadaveric transplant team. So they are the front line. They work with the donor and recipient, try to understand, establish various issues. Next is we have an hospital ethical approval committee before it goes to a government approval committee, which is a mandate from Supreme Court in order to avoid the illegal trade. So we have 5 members. The members, one psychiatrist, need not be psychiatrist, can be clinical psychologist, can be psychiatric social work, one pastoral in the hospital, one person from the medical, but this team should be independent of the transplant team. If this team consists of a surgeon or a nephrologist, the purpose is defeated. So we have 5 members, and each one of us we independently evaluate, and for independent evaluation we have guidelines, and after that we pool the data and jointly we discuss in person and through the data, and then even if one person out of these 5 people say there is no altruistic purpose here and there is some doubt, so we veto that and we say that it should not be allowed. Okay. So because of that, like recently, to give an example, that there is kidney bazaar racket busted, 3 held, and the person who is showing, who was the donor earlier, is a person who is involved in this racket now. He is getting more people to, and a very extensive kind of plan exists. And when you look at, they have given even the hospital name, doctor's name, hospital name. 3 years back again in Frontline, they gave all the patient's name, doctor's name, hospital name. So we have to really protect in an institute or as people involved in science and progression and human life. So how to prevent these things? They are very, and media how it projects these kind of things. So it's in this also 3 years back in Frontline, St. John's name is not there, whereas other hospitals, other doctors' name is there. So that is an indirect kind of compliment for our team. We are able to filter out correctly, but even then we have some kind of an experience where we had a lot of difficulty how to decide this. Then specified protocol, we have a specified protocol. So, like it consists about 3-4 pages. We have made it really simple, because if you make it too complicated, time consuming, and then like sociodemographic data, then reason for renal transplantation, then some of the details are given by the transplant team. Then the donor profile, name, age, sex, education, income, address, occupation, relationship with the recipient, the pedigree, duration, dependency, work or professional relationship, any such kind of partnership, and these kind of things are there. One is trying to give so that the partnership continues or the business continues like this. So, it has to be assessed. Then donor profile, medical history and diagnosis, current and past, psychiatric history and diagnosis, current and past. Then we have principal reason for organ donation, verbatim report, we document what the patient says for the question why you want to give, exactly that is noted, and whether the same reason is given to 5 people when independently evaluated, is there any mismatch, and then from that whether to check is there any altruism. Then witness for the above statement, key family person of the donor, we will have to note currently presence of family discord, marital separation, social isolation, occupational dysfunction, present economic status, legal problems, yes or no, if so specify. Then understanding about organ retrieval procedure, consequences, whether it is good, average, poor, if so then it has to improve before ethical clearance. Then informed consent obtained from the donor, interview of key informant of the donor, whether husband or a son or a uncle or a aunt. Then interview of the key informant of the recipient also. So, we will have to talk to them. Then remarks and ethical committee members, they put a remark, and all these are independently evaluated. So, we have some kind of a specified protocol we follow. Then assessments are independent as well as joint, because if you leave it independent, some of the points will be missed. I may evaluate, I may say, oh, it is altruistic. To give an example, so 2-3 members, we felt that, oh, there is a fantastic altruism, a maternal uncle wants to give to a child, and there is absolute a relationship is there, although a distant relationship. And but then later on it was found, because of the modern technology, to ask for the proof for the relatedness. When people ask for a photograph, and then one of the team member in the photo, they felt that there is a curtain on one side is different than the curtain on the other side, and is there any imposition of photo, and trying to show in birthday party the uncle is also attending, so he is an uncle and he is willing and he is giving. Okay. So, there are many such examples, so which others did not have the benefit of looking at the photo. So, we just looked at the person, interviewed the family members, and then we felt, yes, they are very close knit family, they are related, and there is altruism. And so, this is just one example. There are many such examples. People even try to bring false certificates, even marriage certificates, marriage photographs, and so people have to check from varieties of angles. Altruism, relatedness, this is the most difficult thing to evaluate. Even if they refer a patient to me, after 7-8 years of doing this work, first doubt comes in my mind, there may not be any altruism, they may not be related. I start with that premise, which also is not correct. I have to correct myself. I have to first think there is an altruism and there is relatedness, let me start. Strict confidentiality we have to maintain. Like I mentioned to you, what questions we ask, if some of these touts which they come to know that these are the questions they ask, like when you go for a license or something, they will ask this question. Like that, there will be a problem. So, you must strictly keep confidential, and also confidential to the transplant team, our report. So, our group, what we do not mention in the letter, for this reason we are not allowing. The moment we leak that, and that is available, people try to overcome that reason. Okay. So, our letter shows just 2 lines saying that we are not allowing this. Case vignettes, related, conventional, related according to the Human Act. This is the Transplantation of Human Organ Acts 1994. It gives various guidelines, and according to this, related means son to father or mother, or daughter to father or mother, or that kind of a relationship, not even wife to husband or husband to wife. That is unconventional. So, when it comes to related, genetic, HLA, you have to establish the proof. Suppose somebody is blood related very far off, then again it should come under probably some way of assessing, like how you assess unconventional. Otherwise, in our country, people will always find relatedness, and that is one of the biggest loophole in this. So, the law is not able to exactly create a law to overcome this. Okay. So, conventional and altruism. So, altruism, many times it is there, sometimes it is doubtful, and like for example, there is a related conventional. One of the recipient brought his brother who was living in the village for many years. They never bothered for each other, and when the brother was brought as a donor, when we evaluated, we felt that brother is mentally retarded. But then this is a brother who is working, is supporting that entire family there sitting in the village. So, the question, ethical questions do not stop at no, I will not allow this. Question comes up, if this fellow dies, this whole family dependent on him, what? So, in order to resolve these kind of issues in some of the big books, like this is how I found ethics and kidney, like how one organ can make people in the world preoccupied and work for decades and decades and write chapters and chapters and talk, and still they will not give solutions sometimes. Okay, this is a wonderful book, Ethics and Kidney. I do not know whether any such books are there, Ethics and Heart or Ethics and Brain, Ethics and Eye. So, this is a nice book. They have written in the later chapters the issues in the developing countries like Japan, China, Africa and India. In India, the authors are Jha, I think, Dr. Jha, who has written maybe from AIMS or PG.